Welcome to the Panza Panza Forum. In the Yoruba language, the word panza is usually injected into poetry to express an uncomfortable, uncensored, and inconvenient truth. The Panza Panza Forum is candid conversations about the life of African immigrants in America as it relates to their adaptation to their new home. While some may find it easy to integrate and can balance between retaining the original African culture while accepting the culture of their new home, many continue to struggle to find a balance between both worlds.
Hello and welcome to Panza Panza Live. This is a podcast where we discuss the lives of African immigrants and their assimilation into Western society as they raise younger generations in a country that is quite different from their own. We also explore the experiences of children of immigrants as they balance the African and Western cultures. We present to you this informative, interesting, and expansive dialogue about the intricate experiences of African immigrants in America.
Welcome to Panza Panza Podcast, the platform where we engage in deep conversation about the experience, challenges, and resilience of African immigrants navigating life in the diaspora. I'm your host, Kemi Seriki, and today we'll be diving into the critical but often overlooked topics of cardiovascular health of African immigrants in the United States. We often talk about immigrant migration in terms of opportunity, education, and adjustment, but rarely do we discuss how the physical, social, and emotional transition impact our health. I'm joined today by Dr. Oluwabunmi Ogungbe, an assistant professor at Johns Hopkins School of Nursing and the Johns Hopkins Bloomberg School of Public Health. She is also a faculty at Johns Hopkins Center for Health and Equity, an associate faculty at the World Center for Prevention, Epidemiology, and Clinical Research. Our innovative work include developing and testing culturally tailored intervention to improve hypertension control, implementing the novel approach to enhance diversity in cardiovascular clinical trial, and using advanced epidemiologic method to identify multi-level determinants of cardiovascular disparities. Dr. Ogungbe is a nationally recognized cardiovascular nurse scientist whose groundbreaking research focuses on improving cardiometabolic outcome among population most impacted by health inequalities. She leads multiple NIH and AHA funded studies integrating digital health, community engagement, and implementing science to advance cardiovascular health equity. In this episode, our conversation centers on our studies examining migration-related weight changes and cardiovascular health among African immigrants in the United States, exploring how factors like acculturation, stress, environment, and access to care shape health outcomes. So thank you so much, Dr. Ogungbe, for joining me today. It's such an honor to have you. You don't know how excited I am to have this conversation with you.
It is my honor as well to be here. I'm so excited. Thank you for that beautiful introduction too.
Of course, you see me with pride, because as African immigrant, people just don't understand the journey, and they don't understand how we came to be in the position where we are. The struggle that brings us to that position. They just say, oh, they occupy position, but you don't know how they get there. So in the beginning, I want to talk about your personal journey. And as I always regularly ask my guests, can you talk a little bit about your background to our audience as to where you were born, where you spent most of your childhood and adult life?
Yes, I will be happy to. And you're absolutely right. The end goal is also as important as the journey, or the journey is also as important as the end goal. We have to talk about how we get to certain places. So as you said, my name is Bumi, which means I'm Yoruba. My people are Yoruba from Ondo State. My dad is from Ondo State, Akoko, Ikpe Akoko. And my mom is Ekiti. So shout out to all the Ekiti people. I know a little bit. We can speak a bit of Ekiti.
Okay.
She's from Igede in Ekiti State. I was born in Ikare Akoko. So, and actually both my parents still live there, Ikare, and then a little bit in Arigidi Akoko as well. And that's really where I grew up. We spent some time in Lagos for a little bit, But then we went back home again. So most of my later childhood was spent in Ikariakoko. My secondary school was actually there as well. I went to the Federal Science and Technical College, Ikariakoko boarding school. So spent that time there, and then eventually went to LAUTECH, Ladoke Akintola University of Technology in Ogbomosho and Oshobo. At the time, it was still Oyo and Osun State. So I spent time in both because I was in the clinical sciences faculty. Yeah, that's my journey. And then, spent some time in Abuja working, did some volunteering. I worked a little bit in Lagos before I then moved to the United States.
Wow. So you came to United States to do your bachelor's or master's degree?
To do my master's degree, because I had already completed my bachelor's at LAUTECH in Ondo State, and I served as well. I did my NYSC too in Nigeria, and then right after my NYSC was when I moved to the US to do a master's in public health.
And NYC, for people who may not understand, is part of a graduate, student from college in Nigeria or university, I would say. What does that entail?
Well, it's a beautiful 1 year of paramilitary training. So it's mandatory. Let's even start from that. Everybody who has a bachelor's degree, who has finished a bachelor's degree at college, or let's just, who has finished that stage is often is required, mandated. There are some exceptions, but most people are mandated to serve in the National Youth Service Corps. It's a 1 year mandatory service where you're first of all sent to a boot camp. So there's like a 3 weeks camp where there are paramilitary stuff. They do the left and right. So you learn how to march and you learn how to wake up really early at 5 a.m. once the Beagle goes. And then there's the Mami markets and all of that fun. And then you have a platoon. You have a platoon leader. It's very interesting.
And that's a lot of time it shapes your character anyway, to be able to face the challenge that you face in a foreign country like United States.
Absolutely. Absolutely. I think it also helps to reinforce some home training. For instance, in my home, my mom used to wake us up at 5 a.m. for prayer. So the Beagle would go at 5 a.m. At the camp, and I was like, oh yeah, I'm used to waking up at this time anyway. That's fine.
So many Africans migrate for different reasons, whether to pursue education, escape conflict. At the same time, this movement has been led by concern about brain drain or highly skilled professional leaving the countries. From your perspective, what influenced your decision to migrate to US?
That's a great question. So mine was for education. I really wanted to do more with what I have been given. And what I mean by that is just what my family and my grandmother before my grandmother and the people who have come before me, I felt that I needed to do more with their sacrifices and with what they've given to me. So that's one. And then the second one was that I felt that I could do more. If I could attain certain educational attainment, if I could get to certain places, it might open up more doors for me to be able to go back home and do something different or help a lot more people. And I think the third thing, which is actually very important to me, is also to be able to show examples. There were some, but very few, examples of women that I knew when I was growing up. For instance, I like to tell the story of how Dora Akunyili used to be my example. Actually, two examples. My mom would use an aunt. I love her. Her name is Dr. Mrs. Adeniran. She's probably one of the first women who had a PhD at the time around me. And so my mom will use her as an example that, see, she had a PhD. So a woman can have a PhD and you can ensure that you have a PhD too. But the point is I saw some of those women and I thought to myself, I can do this. And I maybe somehow, even not knowing it, I could be an example. So a lot of my passion has also been like young girls, young women, even older women too, to be able to show and tell people that there is a path here. It's not all bush. We can make a path for ourselves, and we can attain whatever educational level that we want.
And I'm so glad you said the reason you migrated, because even looking at some of your research, I see that you coordinate with many other people in academia in Nigeria to be able to coordinate effort together, to do research together, to bring out all this work so that people will be able to reflect on it and use it as a source of, education to teach other people globally.
Yes, 100%. A lot of my work has been, yes, I do some work in the US, but we are very intentional. So the people I work with, that's Ivan Kamada Mansur in the US here, we work very closely together. And one of our shared goals is local global collaboration. So some things we know we can do here locally in the US, some things we know we'll do better globally. We actually have a number of ongoing studies in Ghana and Nigeria together. Actually, a few months ago, I was in Nigeria and Ghana, and we are trying to do the same study in both countries. And we are collaborating with people like Professor DK Oji. He's great in the hypertension and cardiovascular spaces at University of Abuja. Dr. Mrs. Dele Ojo at the Ekiti State University. We have a number of collaborators back home that were like, yeah, we are here, but we want to bring things back home. We know that there's a lot of need. There's a lot of need back home. There are a lot of wonderful research that we are doing here that we can take the learnings back home. But you know what's also important? We have a term called reciprocal innovation or GLOCAL. So we also know that there are some things we can do very well back home that we can learn from and bring here. So that's what, for some of our work, that's what we do. We do some like trials or some studies in Nigeria and Ghana, and then we learn from that process, and then we try to replicate here in the US, and then vice versa as well.
Wow. That is so important. That is so powerful. It is so important what your team and the people you're connecting with are doing. Because according to the research, Nigerian lifespan is low even among other Africans, where people are dying at the age of 45, 50, 55 years old. When somebody reach age of 60, people are celebrating that, at least because it is something so common in that society that somebody at least live up to 60 years old. And compared to America, they will say, that's a baby. That's a young person. Not really a baby, but that's a young person at the prime of their life.
Yeah. I mean, how many gone too soon have we since, right? We have the obituary. It's set on WhatsApp, on Facebook, printed papers. It's gone too soon, gone too soon, gone too soon. And like you said, people are in their 60s and we celebrate, we roll out the drums because we want to celebrate a life well lived. And that is true. We should celebrate a life well lived because that's part of our culture. At the same time, we need to investigate why that is happening. We need to investigate. There's a word I actually have a problem with. I've said this so many times. When people die suddenly back home, we say they slumped. The person slumped and died. There's really no medical term as slump. Somebody slumped and died. Yes, maybe they suddenly collapsed. Either they're having a stroke, they're having a heart attack, they're having an episode. Like, there are often reasons behind that. But because of the way our system is set up, or should I say, non-existent emergency care, and because we don't really investigate what's happening, we don't really do preventive care. A lot of people walk around with uncontrolled blood pressure. I told you I was just in Nigeria. We did among the study team, our team in Nigeria, where we were just doing training and showing them blood pressure measurements, different techniques. We had a lot of people with uncontrolled blood pressure. They did not know. These are healthcare workers, nurses and physicians and community health workers. Even them did not know. They had, I haven't checked in a while, so I didn't know that my blood pressure would be this high. So all of that to say, you're absolutely right. There are a lot of undiagnosed cardiovascular disease and other conditions back home. And, people don't really know. And then the next thing you know, gone too soon. We don't have to accept that status quo. We can do something about it.
Yes.
We can do a lot about it.
Yes. Yes. Thank you so much for this. I think there's so much I would love to talk to you in the future for another episode, because we have to coordinate this effort to continue to educate people, because that's what it's supposed to be, and to bring this work out in the global world where other people could listen to it. So I want to bring you back to you migrating to the United States. What are some of the challenges that you experienced during your earlier part?
Oh, that's interesting. So continuing the story, I migrated to the United States and I lived in Mississippi. So actually my first city or my first state, yeah, you know what that means for people who have lived in the US and who are familiar. It was good to me, I would say, but I think it was also the first time, and I think as many of us African immigrants often recognize, it's the first time, if you've not been previously aware or part of like the Pan African movement, it's the first time you're like, I am absolutely Black. I am, in quotes, no longer quite Nigerian or Yoruba. I am now Black, and I have to understand and what's really going on here. So I lived in Clinton, and I was going to my master's was at Jackson State University. So I spent a lot of time in Jackson, and I had to do a lot of learning. I had to understand, the civil rights movement, what does it mean? What am I saying? Because I could see, right? I saw what was going on and how people were interacting and how places were different from each other, and I couldn't comprehend it. And I think the one experience that I can never shake off is when I visited the Mississippi Delta, and I was like, oh, I am sure I'm back in. I don't want people to be offended, in a village back home. I'm like, what? Even Kariakoko, where I grew up, we have a lot more things that what is going on.
Yes,
Just that really seeing the stark differences in some areas and what they, and I couldn't comprehend that. Yeah, I was visiting the general hospital, and they said, yeah, this is the only hospital in the entire county, XYZ county. And I'm like, wait, what do you mean it's only one hospital? This is the United States of America. This is supposed to be the richest country, in some measure in the world. So all of that to say that I think that really woke me up even more made me more aware of, obviously, race relations, how that all those structural laws that has just persisted, all those reasons for the civil rights movement, and how we can't just relent, and also how that impacted me as an African immigrant and the African immigrant community. Because as you know, once you present without opening your mouth, at least for me, without opening my mouth, I am Black. I'm a Black American. That's who I am. And then I open my mouth and people go, oh, I detect an accent.
Where
You
you
from?
from?
Oh, your name. How do you say your name? And then people start to treat you a little differently. But even that in itself can be problematic, right? Because we really should treat everybody with decency as human beings, without discrimination or stereotyping. So I think a lot of my work in when I first came was educating myself, getting my public health degree, but also educating myself socially, and how the way things are set up socially, how that is really then impacting people's health. And then I worked in the hospital at the time as a clinical nurse. That also woke me up some more, because I saw it. I saw how people are treated differently. I saw how people are referred to differently. I saw how some people just did not have access, and by the time they came through, things are already the disease has progressed way too long. I started to see a lot of those differences, and that's when I was like, yeah, we cannot just be talking about the problems. We really need to be more solution oriented, both within the larger Black American community, but also specifically in the African American community, and then as well in the African immigrant community, and also our Afro Caribbean brothers and sisters too.
Yeah, I mean, that's so important what you just said. They combine everybody together. You are the same. You're Black, okay, you're African American. You could connect with African American with their struggle. It's the same thing that you experience, issue of race. Oh, the Latinos also are immigrant, or the Caribbeans also are immigrant. You could connect with them without looking at the unique issue African immigrants are actually maybe experiencing or going through. Even bringing in academia, when when you reach that, how was that for you in navigating that environment?
Ooh, that was that was a little interesting, right? I had to find ways to find mentors and sponsors who understood. And I'll tell you a very common thing that people would say to me, including my colleagues. They would say things like, I actually had a colleague one time that was saying, I think they did not understand the visa restrictions, because you have to be on F1 visa. You can only do 20 hours per week on campus. And they did not understand the visa restrictions. And they were trying to suggest that they have a job and that I could come do the job with them. And how we have to repeatedly educate people that, no, excuse me, I'm on a visa, I can't do that. Or my professors or the people I work with, I really could not be on certain grants because of my status. So being very, very strategic really helped me. Then I started to say, okay, to be honest, I was really looking for Black women. I was like, okay, she's Black, she's a woman. If she's an immigrant, even better. So I had mentors that really helped me, and people we call sponsors as well that really helped me, and that really facilitated my transition to Johns Hopkins as well, because I went then from Jackson State to Johns Hopkins really by virtue of obviously applying to make sure I get in, but also by identifying women who were doing, or people, especially women and Black women, who were doing the kind of work that I was doing, which is heart health and especially among African immigrants, but also who I knew that they were exceptional. They knew exactly what they were doing. They had a reason for the work they were doing. And I found them and I followed them. And I've been attached to them since. I'm like, hey, you guys
That's
are
your
my people.
village.
You're my family here. You
Yeah.
figured something out. I want to know what you figured out. I want to figure it out too.
That's your village you created. So what would you say you appreciate mostly about America?
I do appreciate the possibilities, I think is what I appreciate about America. There's this sense of possibility. And yes, sometimes when we dig deep, it may not be as simple or as easy. And sometimes in some spaces, it may even be a fantasy. So I want to acknowledge that not everybody may feel that sense of possibility. But in my own personal experience, there is this sense of that if you can dream it up, if you have support, you can work towards it and maybe you will get it, whatever it may be. And that's what I like. There's a little bit of the sky is big enough. All kinds of birds, whatever species can fly. And I think that does help. And that may show up as being able to access some opportunities that just by virtue of it being the United States, it presents itself that way. And that's one thing I do appreciate about the country.
And I like the proverb you just throw it in now. This the Yoruba proverb that the sky is big enough for every bird to fly freely without touching one another.
Yes.
Okay. And you reach as much possibility as possible. I use the same proverb for my children. I use it for many people that I've come across that this is the Yoruba proverb. So you could see through that and see the possibility that is available for every human being. It depends on how high you're willing to fly and how you want to be able to connect with others. So regarding your research and the motivation, as I said earlier, our conversation centers on studies examining the migration-related weight changes and cardiovascular health among African immigrants in the United States. So for so many of us in the United States looking for a better opportunity, but along the way, we face new challenges, long work hours, stress, lifestyle changes, and sometimes healthcare systems that can feel confusing or out of reach. And unfortunately, many people in our community often seek medical help. They don't seek it until when it becomes critical, and sometimes ending in an emergency room where the condition couldn't be prevented or managed, or if they come to the hospital earlier, it could have been managed, whereby it doesn't need to lead to end of life or critical condition that is unlivable for so many. So this happens a lot for many reasons, which may be due to lack of insurance. And we know high cost of healthcare in US, or even the mindset of many of our people that as long as I'm moving my body, I'm fine. Okay. But prevention is the key. And that's exactly why today's conversation is so important. So on your research studies, can you talk a little bit about what inspired your research focusing on cardiovascular and metabolic health among African immigrants?
Yes, absolutely. And thank you for that preamble. I think it really would help people. There are some key things that inspired me really wanting to do that kind of research. Number one is cardiovascular diseases and maybe cardiometabolic disease. That's the top cause of death. That's the top killer in the US and globally and in many countries. So if we pull up most countries and then we say what kills people more? It's often cardiovascular disease, heart attacks, strokes, top killer. So that's number one. The second reason is in the US, among African immigrants, there isn't a lot of research. Now, there are now more and more of us doing this work, but we still need more. We still have more work to do. There isn't a lot of research. And like you shared with me just before we started recording, right, that sometimes when you want to pull statistics on African immigrant health, you go to Canada, to some of the Canadian studies to pull that. So there isn't a lot of work that has been done. And actually, I was also sharing with you that we are trying to put together like a longitudinal cohort study where we actually recruit African immigrants and then we study their heart health and their metabolic health over time because we don't have such. And that really should have existed. And for some reason, just has never been done. And they're trying to do that. So that's another reason. The other reason, which is more personal to me, is because my own grandmother died from complications of heart disease. And if most of us really just need to look within our families, there's probably someone with hypertension or diabetes or a combination of those or has some heart condition. We may not even know because it's maybe not has not been diagnosed, right? And then, like we said earlier in the conversation, God forbid people suddenly die. Well, oh, they died suddenly. We don't know what happened. It's often because of something that is underlying that was never really diagnosed or managed. So those are some of my reasons. I have that personal experience, and I know that if we had had just a bit more research, if we had had just the access to healthcare, I know that my grandmother would have lived longer than she lived for. So I know how important this work is. I know that more and more people can live longer and healthier lives. So not just longer lives, but healthier lives if cardiovascular conditions are diagnosed early, if we screen properly, if people access preventive cardiovascular care. So knowing what their blood pressure is, knowing whether, their blood sugar is climbing and their A1C is climbing. There are interventions we can do to reverse this early. But even when we can no longer reverse and the diagnosis is established, we can have interventions that would slow down the progression, that we ensure that, if it's taking blood pressure medication every day, we encourage people, see, it's okay to take this medication because we don't want this to progress to stroke. We don't want this to progress to heart attack, right? These medications are safe for you, will support you as much as possible. So there are things that we can do to prevent, like we said earlier, too many gone too soon, especially gone too soon as a result of cardiovascular conditions.
Your research, we talked about before that you co-author that title Comparison and Cardiovascular Disease Risk among African immigrants and the African Americans. Your study highlight that African immigrants are often grouped with African American and other racial minority in United States during health research. Why do you think this is problematic, and what are we missing when we fail to study African immigrants as a distinct population?
So there's something in research, a term in research that we call heterogeneity, and that is the concept that there are differences that we can see when we study a sample or a population. And those differences can sometimes help us explain a health trend, a pattern that we may not be able to explain if we lump everybody together. We do something called like subgroup analysis. We put people into their groups and we say, okay, what's going on here? Why is the health pattern in this population different from the other population? But what's happened? And all of us, especially all of us in the US, have experienced this, right? Maybe some of the first few times, anytime, every month or every year, whatever, we fill out the form and they give us the boxes. And the boxes are African American, Black/African American. And I think for some of us, maybe the first time we're filling that form, we're like, which one do I even pick? Because we've had people say they don't even know which one to pick because I'm not sure. Am I Black? I just came from Ekiti State. I don't know if this applies to me. So there is that already, right? That confusion. And then we learn over time that, yes, we just check the Black and African American category. And while, yes, that could be a convenient way to collect data, what that has meant is that a lot of our data, especially the health-related data, are aggregated together in a way that hasn't been helpful to a lot of the ethnicities, the Black ethnic populations. And I'm saying that being able to separate the data for our African American population, our Afro-Caribbean population, and our African immigrant population is important because it will help us a lot. The context and our life circumstances are a little different, right? For instance, for African immigrants, there are effects of colonization. There are effects of just our own cultural background. There is the migration process, like we were saying earlier, like you were really saying earlier, people migrate for different reasons. People are fleeing conflict and places. There are impacts on their health, right? Mm-hmm. For people who are looking for economic opportunities, and that's why they've migrated, there are some impact on their health. There is the psychosocial part of this. But when we don't separate the data and we lump everybody together, we are not able to see these patterns. We don't really know what that post-migration journey is and what impact it has had on their health. Some of the work that we've done in our work is to look at how much length of stay. Because there used to be like the healthy immigrant effect where we say, oh yeah, when immigrants come in, they're healthier than people in the host country. But we are really challenging that because that's not necessarily the case, number one. And then the second thing is that the longer people stay, we've seen that there's a decline in their health status. People tell the example of how, when they were moved, before they moved to the US, they, for instance, had a certain body weight. And then when they moved, within 6 months, there is a change in their body weight, right? Even things like health behaviors. There are things that people do back home that's a little different That's what they do here. This is a more car-dependent society. Most people have cars. People are working 2, 3 jobs, like you said in that preamble. So people are not really working. This is different from where people could walk from Mushin to Ojuelegba, right? Our lives and our health behaviors are different, and it's important to measure that. It is important that we understand what's happening. You know how they say if we don't define and measure a problem, we can't really find solutions to it. So if we don't really know what's happening and why there are differences in our health patterns, it will be hard to find the solutions to it. So there are several other reasons we could talk about it.
I know in the study you mentioned that the immigrant who had spent 25% or more of their life in United States had almost 3 times the risk of unhealthy BMI change. What does that tell us about how long-term effects of acculturation on health has an impact?
It tells us a lot. And I would say that the only reason we were even able to analyze and show that results is because we had to recruit mainly African immigrants population, or we had to find the data that allowed us to do that. And we also have some studies where we recruit mainly African immigrants into the study. So there are different ways to do this. We can either look at the length of stay. So if someone has lived in the US for 2 years or for 5 years or for 10 years, right? But the one you pointed out is we looked at the percent of life spent. So if a person has spent 25% of their life, some people may have spent 50% of their lives in the US compared to their home country. Some people may have spent 10%. So essentially, if people have spent more time in this country and adopted the regular everyday life activities, it does have an impact on their health. And that's what we've shown, which means that if people are not being careful of their diet, if people are not really doing the physical activity, recommended physical activity targets, if people are not seeking preventive health care, yeah, they probably will have a higher chance of this cardiovascular.
And part of what I was also reading, your findings suggested that those who migrated for educational reasons show higher, more unhealthy BMI changes compared to those who migrated for economic or for family reasons. Can you unpack that to the listeners? Because I thought maybe somebody who for education will be much more have a better health.
That's what you would think. And that's why it's important for us to look at these results more closely. So because as you know, in the US, educational attainment is linked to occupation, which is linked to health insurance, which is linked to access to care. So if a person, for instance, they have a good job, they are more likely to have health insurance, which means they are more likely to go to their doctor to get a diagnosis. So people who have a higher education attainment are more likely to actually have a diagnosis, and that's just by virtue of having access to care. Whereas people who may not have, a job where they're able to get insurance to their employer, they don't really know what's going on. And then they just, oh, do you have hypertension? They may have uncontrolled blood pressure, but they will probably say no because they are not going to access healthcare. So it's really in terms of that result is particularly about who has access. It's about who has access to care and who is actually getting the diagnosis. And we think in our group that we would rather people are aware of the underlying condition than not being aware and thinking everything is okay. And then, God forbid something happens, have an health event, or like you said earlier, they have to go to the emergency room because suddenly something is not feeling okay. So yeah, it's really about that. It's about who has access and who is able to go in. But what's also more interesting, especially in the African immigrant community, is we have a colleague who does this research, is the education occupation mismatch, right? In the African immigrant community and some immigrant communities, you have people with PhD holders who are working in the factory, or people who were trained as medical doctors back home, but who are working a job that is not aligned with their training. So we also have that mismatch. And those are the things that we need to understand, because we can't just say that because a person has a high education attainment, that means that they have a better job, like I said earlier. Not necessarily in every case, because we know in our population in particular, there's often that mismatch.
It's so important what you just mentioned, because people with a very high education who came from Africa or a different part of the world, and they were top managers or they are doctors from their country, but then they come in here to do menial work. And emotionally, it has something psychologically, it affects them. And that psychological aspect of it leads to also physical health. issue because
Yeah.
you realize yourself that, I'm underemployed. And a lot of people don't understand that. And that's why this kind of studies is very, very important because all these nuances, if it's matched with other population that they don't experience the same thing as other immigrant experiencing, it will never come out.
Yes. Oh, yeah. What you just said, and then we just oppose or we add on top of that, that people have to remember, I know how I left home. Oh, we need to send that monthly money back home. There is that additional stress, right? We get those calls I hope I pray we continue to get good calls from back home, but we also know that sometimes we get calls. Somebody gained admission. There's money to need. There's a funeral. There are those things that are part of our culture because we have such a communal culture and we are not individualistic and we feel obliged. In the example that you gave, yeah, someone who is a physician who was trained back home, they come here, they don't quite have the opportunity yet to get their licensure here and to do so they're having to work a job that is not commensurate with their training. And then on top of that, they're now having to work like 2, 3 of those jobs just to make ends meet to keep and feed their family here. But they also have to worry about what's happening back home too. Because like you said, if they were in a managerial position back home, it means they were probably one of the, taking care of a lot of extended family and they can't just drop everybody like that. So you're right. There's that psychosocial aspect of it. There's that stress that that people experience that they may not even realize. And that definitely shows up in the health. People are not resting well. One of our dietitians who works with us, and she's also originally from Ghana. Her name is Adeline Usani Uba. I love her. She talks about how she would tell people, people will come to church. They'll come from night shift to church, and then after church, they have to go to another job. And that she would tell them, when do you have the time to even rest? When do you have the time to properly cook a meal that will nourish your body? Right? When do you have the time to think about your own health? And yeah, you're absolutely right. If we continue to just combine data without disaggregating the data, we would not know. We would not know the impact of some of this. And that's part of the problem. And that's why, the work that I do and some of my colleagues, that's what we are trying to do. That we love everybody who is part of the Black community. At the same time, we think it is important to look into specific communities. Because if we don't do that, we would not know what solution would work. It is not a one size fits all. One solution will not work for everybody. So if we don't look into where the pain points are to see what's the issue? Why are people in the community, why are they not, for instance, why are they not getting physical activity? People will say, in my job, I lift a lot of heavy things already, and I have to work 2 or 3 of those jobs. When do I even have the time? I sleep for 4 hours. I barely sleep, night shift, and all of this that people are having to do. But we can then say, rather than recommending for you to go to the gym, you can do 15 minutes. We call them exercise snack. When you get a break, instead of just sitting down and eating, you can actually, walk around or, you can do like exercise snacking bits. So those are the kinds of cultural tailoring that we can do. But we need to understand the underlying issue first. If we don't, it will be hard to find solutions.
Blood pressure does not really interpret itself openly because you could have high blood pressure and you don't even know that.
That's why it's called the silent killer.
Because just to give you my own person, I went to my doctor the other day. You know how they put the blood pressure stuff on your arm, and then he said, it's a little bit high. I said, maybe because I'm moving around, and I went to the gym this morning. He said, well, I think maybe that's what it is. Then he asked me to stretch my hand out like this. And I did that. Then he said, okay, it's okay. I said, thank you, because I just want to find out. I wouldn't even feel like, okay, maybe it's high, maybe it's not high, and we have to educate our population about this. So going into culture and lifestyle and acculturation, many African immigrants say the food back home is healthier. How does this quality of food and lack of physical activity pattern, I'll say activity pattern back in Africa versus here in US contribute to weight gain and cardiovascular risk?
That's an excellent question. And it's very, very nuanced as well. Because it's not, when people say, for instance, this back home was healthier or that back home was healthier, it's sort of a blanket statement. And that may not be true in every circumstance. And I do for this medicine research as well. So I do understand that there are some nuances here. There are some foods that we used to eat back home that were healthy, but not necessarily in our cases. There are some cooking practices that we have that has evolved over time. I'll give you an example, right? because there were periods when we didn't really have cold storage, so we evolved into storing like fish, with dry fish with a lot of salt, right? And then we like dried fish. But then when we use that to cook, we forget about the salt that we've used to preserve it. And sometimes we add additional salt. And then we had, seasoning cube as well that already has a lot of salt. And all of this has, salt. And that's why for high blood pressure, we encourage low sodium. But people don't know. And then we continue to eat this very high salt diet. So there are things like that we've evolved, or even in the way we prepare our vegetables, right? It's a little better if vegetables are likely not overcooked. But once we put the vegetable in and then we cover it and then we continue to cook it. But that's also understandable because we're trying to kill parasites. We're trying to make sure that it's all very cooked and that it's safe to eat. And that's how we've evolved. So, just talking about some of those cooking practices that we had to adopt because of our context. But what we often tell people is we can make changes. It is true that we like to say, that's how we've always done it. We'll continue to do it like that. So that's true for some things, but for some other things, we can make changes. We can make personal changes in our homes. Maybe for the vegetable, let's just saute. The vegetable is good. We already eat a lot of vegetable in our, we can probably even eat more in our culture. It's about taking a step back. It's really about, number one, moderation, and about in my research, we don't criticize our food because we can't just say, oh yeah, all the food is bad. We should only eat salad. No. Because we know, number one, that doesn't work. People will say, in my home, we only eat pounded yam and egusi, and yes, I want to be healthier. So we try to work with where people are. We meet with where they are and say, yes, we know this is part of the culture. We don't want you to necessarily throw all of that out of the window, but there are little small steps that we can take. So, in the example I was given, we can cook things a little differently. We can add something that we didn't use to add. It will still be a similar flavor. You can reduce the oil that we use. Rather than using seasoning cube, we can use herbs. We can use natural herbs because, the flavor will still be there and we're not overloading the soup or the sauce or the broth with salt. So those are like changes that we try to encourage people to make.
It is so important what you're saying. And one thing people are not realizing, back home, people, you said it before, they could walk miles. Yes. They sweat a lot also. Yeah. Maybe that would take sodium out of the body or something. I'm not sure. I'm not in science. So there's so many things that they do. I remember my grandmother and many of their age group at that time, they would say, as long as you have vegetable and a little bit of meat, they don't even give you meat too much. Not because they know the health impact of it, but they just said, it's only somebody who is greedy that eats too much meat. So just eat your vegetable and your fufu, and that should be good enough for you. So they have a lot of other things that they do. And the meat back home may be different from what you eat here. So you have to understand that you need to work on all these things. You can't just say, and even if you want to eat our food, maybe, minimize it. Instead of big amount, we could cut it down. Instead of having yam every other day, you could see, 3-5 pieces of yam, you could have 2. And then gradually it cut down a little bit. What do you think of that?
Oh, 100%. It's about combining the wisdom from our grandmothers and our grandfathers and the wisdom of science, and then making our decisions. And that's what you really just described. It's knowing that, yes, we can keep eating our vegetable. We can cook it differently, right? We can reduce portion size rather than a mountain of eba. We can reduce that to a little bit. And you're right, the body and the palate starts to adjust it. We can train our bodies to adopt healthier lifestyle. Because let's also remember, back home, we sort of celebrate, higher BMI in a way. It's sort of cultural. If you're looking, in fact, there are people in my family that I try not to do video call with them because they will say, your color, there's something, I'm seeing all your bone outside. Are you sure?
You okay?
Yeah. So we also need to remember that as well, that, back home, there's a size that is considered okay, and that may not necessarily be healthy. That may not necessarily help our health. So we need to be very strategic in how we make changes. And you're right, back home people walk. It's part of necessity. Not everybody has a car. So we've all learned to, maybe it's just there. You walk it. And like you said, we sweat, we're in the sun. But here, things are a lot more sedentary. everybody is not working everywhere. Maybe other than people in New York. I think in New York City, people still at least work. But if you live in Minnesota or Atlanta or Texas, where are you walking to the highway?
There's no sidewalk.
You end up on high Interstate 10. So so it's part of, understanding the environment and making, like I said earlier, for exercise, we can do exercise snacks in the evening. Let's stroll. We used to stroll back home, maybe with us, daughter, granddaughter, whoever it is. Let's just stroll and talk, because even that is part of relaxing. It's part of relieving stress, right? That we're just having a leisure. We are not glued to our phone or TV. We are actually moving our bodies and moving our minds in a way. So those are things. I think the broader message here, from what you were saying and from what I'm also saying as well, is that we shouldn't just rely or sit in the status quo. There are changes that we can make, little daily changes that we can make that impact our health, from diet to how we spend our time to physical activity and on and on.
And let me ask you, does factors such as discrimination, isolation, or economic hardship play a measurable role in increasing stress and cardiovascular risk among African immigrants?
Yes, 100%. Yes, unfortunately. So, there is something called acculturation stress. I think we slightly started to talk about that later. There is a stress that comes with moving to a new country, learning a new culture, and trying to assimilate. There is a stress that comes with that. There is a stress that comes with discrimination. We've done qualitative interviews in some of our work where we interviewed people and we were trying to understand, why don't you go to do your annual physical? Why don't you go to your doctor? And one of the women, I still remember her voice, and you could see that she was still hurt by it. She was sharing an example. She said, when you go, they can't even pronounce your name. That they won't even attempt to pronounce your name. They won't even talk to you properly. They would like the way their attitude. And I don't want to go to a place where people are behaving like that to me. Nothing is wrong with me, so why should I even go there? Prejudice, the stereotype, the discrimination. Yes, it's impacted because I think even more so for African immigrants, because there's sort of a confusion. I don't know other people's experience, but in my experience, I know the first time I experienced things like that, I was so confused. It took me a minute. My brain was so confused because back home, there's a sudden pride. In Yoruba, I'm meant to be here. I'm supposed to be here. And then you go somewhere, people treat you differently and you don't understand why. It's not, you didn't do something bad. You didn't say something bad, but people are treating you differently and you don't get it. So those things stay with us, even when we think they don't. And that would impact our health. Yes, it does contribute to stress. It does contribute to self-efficacy, even the feeling that we can do something, that we can make changes. It does. And like you said, things like isolation, it can be very isolating for new immigrants, especially if you're not connected with people or connected with people from the community. There are sometimes I remember when I first came to this country, I just want to hear people speaking the Nigerian English or speaking Yoruba. I'll go on YouTube. So I don't know, there was just something about hearing that, because as you know, we have to code switch. There's the Nigerian English, there's the American English, there's the Yoruba, and depending on the setting, when we are code switching, it's almost like we're wearing a persona. There's a way that we speak, there's a way that we present. And then when we are like among other Nigerians, there's a way we are able to relax. So those things does impact us personally, impact our health. And I think that those are things that we should be focusing on. Mental health struggles, it's unfortunately, it's high. There are things like intimate partner violence, which is a problem in the African immigrant community in particular. This is not the time where we continue to sweep things under the rug. We need to open things. We need to talk about it. We need to address them.
That is so important. It's part of this open conversation that in areas where many of our people gather, like churches, mosques, or community events where all this education is needed in order for us to continue to thrive as we're supposed to in this country. And you're so right. When I go and do checkup, for my physician to do a yearly checkup, you will find some of these attendants, the nurses, whereby the way they address you, they talk to you the right way, or even attend to you with courtesy that they give to other people. But one thing that I've learned for anybody listening is to make a complaint. I go in there and I, ask, where can I make a complaint? I call their number and I make a complaint. So next time that employee will be addressed, and they might be able to train them and let them know you have to treat people with courtesy because this actually could affect their health. So I want to talk about rethinking the BMI and cultural relevance. BMI is widely used in health research, but some scholars argue that it doesn't accurately reflect health risks across the diverse population, which, some people may argue about that and saying, at least, my grandmother lived up to 90 years old. Even some from Europe, who you look at some of them who are living rural in Italy or in many places in Europe, and they are overweight. Nothing wrong with them. They live up to 90, they live up to 100. Do you believe the BMI is culturally valid measure for African immigrants?
That's a great question. And you're absolutely right. There's a lot of debate on that. A lot of measures like the BMI, they sometimes are as good as how they were derived, how they were validated, which population was the measure originally used in, right? Because that's how we get the cut points. And yes, it is true that they may not have been validated in every population. Most populations have different bone density, different structures. And even for BMI in particular, for instance, we have Asian specific cut points. We have a different cut point for people who are from Asia, from Southeast Asia in particular, compared to the general one that we use for everybody. There are other things like even, EGFR, estimated glomerular filtration rates that we use to assess the kidney. There used to be like a race adjustment. There are several measures of that, they try to adjust for race, but the bigger point is that sometimes all these measures may not apply for every population. And that's why I'm going to I'm going to say something that I always like to say. I know in the African immigrant population, sometimes we don't like participating in research. I think there is a Yoruba proverb, maybe you will help me, I'm forgetting some of it. And if it's okay to speak Yoruba, something about Tobani, Begbegbe, and then they will be Senkule or something like that.
Yes,
That's what I'm
yes.
saying. Yeah. Yeah. So somewhat, loosely translated into, if you're saying it doesn't concern me, I'm not going to participate. No, it doesn't apply to me. It may end up in your backyard and
Yes.
apply to you. So sometimes we try to, when they say, oh, participate in trials, participate in research, sometimes we run away from that. Well, I don't have time. I don't want to participate. Do you know how hard it is in our studies to recruit from our own community? I will even be speaking Yoruba to people and begging people, this is important. We are trying to lower your blood pressure. This is good. We are not testing a drug. We are testing food. We are testing what would work. We are trying to tailor it to our own population to see if it will work, right? So that when you go to the doctor, they don't say, eat more tunics, eat more beets, things that are not in our diets, but they are able to tell you, there is the Afro DPP program. This is what they did. Take the manual. Eat that instead. It will help you. So, we try to explain, but people will say, no, I don't want. I'm too busy. I don't want to do it. And we understand people are busy. But bringing it back to the BMI conversation. So it's when we don't participate in research or things that end up being measures or surveys or being tools like BMI, it can be problematic. And I think that's one of the issues that we have with BMI. Sometimes it doesn't take account into other things. It's a little limited. So some of the other approaches is sometimes we recommend waist circumference. So just a tape measure, almost like what our tailors do when they want to sew our dress. We can use our waist circumference as an additional measure to BMI, in addition to body weight. There are actually some weighing scales that would calculate like percent of lean body mass, that will calculate like percent fat in the body, percent of lean body mass. So there are some scales like that we can actually get, and those might work a little in addition to BMI and body weight. Those can be helpful.
Yeah.
They can tell a more complete story.
Yeah, because and that's part of maybe confusing and people are not really taking it serious. So I think to reach many people is to be able to talk to a religious organization where they are, maybe educate the pastors and the imam and all these people that, this studies is needed for our community for you to participate. Because that's the only way to reach our people. And for pastor to say, God will only watch, watch out for people who watch out for themselves. So so this message is being passed down, is coming to your way so that to help you prolong life, so that to help our community to excel, to continue to do better. So thank you so much for that. On a broader social determinant, the African immigrant health studies, in your research on social determinant of hypertension and diabetes, you explore factors like employment, health insurance, acculturation, and lifestyle. Can you briefly explain how this factor contribute to vulnerabilities among African immigrants?
Absolutely. And we've also talked about a little bit, we talked about this in terms of the social factors earlier. So there are things called social determinants of health or social drivers of health. And those are things that may not be genetic related or health, directly and biological factors, but they impact our health. So like education, where we live, where we play, our environment, our neighborhoods, the kind of job that we do, what our economic status is, whether we have access to healthcare, whether we have insurance, those things, they contribute a lot. Like we were saying earlier, if a person does not have a high enough education, especially in this country, it might mean that they are not able to get certain jobs, which means they may not have access to insurance, which means they don't have a primary care provider, which means that they cannot just make an appointment and go in and and do like an annual physical checkup. So that's already, a problem in itself. But even the neighborhood that we live in, like we were saying earlier, are there sidewalks? Are the neighborhoods safe enough? Right? Are we able to have a decent sleep? Are there neighborhoods where even the house itself, does it have lead paint? Is it high quality housing? Air pollution, noise pollution, all of those things. There are studies that have shown that people who live close to like airway, it does impact their cardiometabolic health and their blood pressure compared to those who live in more quieter neighborhoods. So all of this does impact our health. Where it gets interesting, especially for the African immigrant population, is that just by virtue of migrating, people are still trying to set up, people are still trying to get jobs, or they're trying to write exams to get their licensure or whatever it may be. Sometimes people don't live in the best places, they don't have access to the best food. What am I even saying best food? Sometimes it's even hard to get food, any food, right? And as we know, in this country, it's cheaper to get fast food than to get vegetable, right? So sometimes people are trying to survive, right? And like we said, sometimes people come in, they're unable to get the desired jobs, and they just pick up any job that they have because they have to pay bills somehow, they have to survive somehow. So these determinants or these drivers, these social drivers, they are even more important in the immigrant community and particularly in the African immigrant community, and they do impact our health a lot. We call them the root causes, the causes of the causes, right? Because they show up. They actually show up in increased blood pressure. They show up in pre-diabetes. Like, the example I just gave, if people are only relying on fast food, they don't have access to fruit and vegetables, even though that's what they desire, but they don't have access to it. People start to have A1C, and before you know it, people have diabetes, and now they have to use insulin or medication, and they don't even have a good enough health insurance. And as we know, that's one. And then the second thing is when people newly come into the country, they don't have access that other people may have. So I know people sometimes who have not migrated, they don't understand this. They think everybody has access to food stamps or to WIC or to SNAP, or everybody has access to Medicaid once they come in. The answer is no. No, you don't have access to any of this. As immigrants don't. So people come in, people will say, oh yeah, you qualify for Medicaid, go get it. No, if people are on a visa, they can't really do that, right? But they have to wait like 5 years to even qualify for any of those benefits. And that's, for those who are on the immigration part, not even those who are on the visa. So all of that to say that there are those barriers that makes it hard to access any healthcare, or even be able to engage in health promoting behavior. And that's what makes those social determinants of health even more delicate or dynamic in the African immigrant population.
Especially those who bring their parents here. I was just talking to someone recently, an elderly parent here, mostly to help them care for their own children. And in most cases, maybe they came in with the green card or something, or some don't even have any access to anything, but just stay home to take care of their grandchildren. Their health may deteriorate because their own children may not know, may not understand that you find a way to get care for your parents, even though your mom or your dad, even though they are here. So what advice would you give to set of those people?
I would say, in fact, and I had to do this for my own parents too. So this is something that I'm also doing in my life. When our parents, our aunties, our mom, our dads, when they visit, it is critical that we find some form of healthcare for them. And I'll tell you some examples that I have explored. In some cities, there are some clinics that will see people who are uninsured or underinsured. They may need to make sure that they qualify, but there are some philanthropic clinics. These are not government funds. These are people who, out of the kindness of their hearts, have seen that there is a need, and they set up clinics specifically for immigrants population. I can give you an example. In Baltimore City, Shepherd's Clinic is one of those. They are specifically focused on uninsured and underinsured people, and it's all funded by donors. Some cities would have that. I know New York has some of that. Boston, Massachusetts, there are some cities that have clinics like that. And I'll tell you the beautiful thing about those clinics. And I often tell the example that I gave in Baltimore City. I've told this to the medical director herself. I went in there, and the care that they give people is so much better than the people who have insurance. And you know why? I was talking to one of the physicians. She was like, because we get to practice medicine. We don't have insurance companies breathing down our neck and saying, oh, it's only 15 minutes. No, like they would spend a full hour with the patient, and they would do everything, and they would cover, if not all, most of it, at least 90-something% of it. I would recommend that please go online. Maybe people can go to findhelp.org, or those are places where you just put in your zip code and it will show you services around. So please go and check and see what clinics would be, and just contact them, call them, go there and ask them, explain the situation, and they will, if they cannot do it themselves in that clinic, they probably would be able to refer to, oh yeah, we know that clinic. That clinic will be able to help. But I think you bring up an excellent point. We should try to find healthcare for anybody who comes to visit. Let us not just think things will be okay because they are aging. People 60s, 70s, 80s, 90s. Those are important signs that people should be very close to their healthcare team, and they should be receiving the care that they need.
So apart from that, based on your research, what kind of health promotion or intervention would be most effective for African immigrants?
Yes, we actually did did like a clinical trial, a study for African immigrants. It's called the Afro DPP study. For those who are familiar, the DPP study, it stands for Diabetes Prevention Program. It was actually commissioned by the CDC, and so they did like the national one, and then they also did one for that was specific for African Americans. And then we thought it's none for African immigrants. Case in point, the what we've been talking about this entire discussion. And so our team with a dietitian who is also African immigrant, we actually took the curriculum and we went through we adapted it. We also had like a focus group with people from the community so they can look to. So, we added all the plantains and all the vegetables and, all our own food that people recognize. So we then recruited people. We went to the churches. We recruited people to participate. And so we had them meet with the dietitian. So we went through, we taught people almost like it was like a cooking, a nutrition class. Like a dietary class. So, and these are people who have uncontrolled blood pressure. So everybody had hypertension and pre-diabetes. So we actually went through the curriculum and we had fantastic results. We published it in JAMA. We had fantastic results at the end. People's blood pressure dropped, their A1C dropped, it just really, their body weight dropped. Not so much A1C, but their body weight reduced. And the dietary quality increased. So there are, programs like that people in our community can access. So that's just one example. Another one that we are doing is more of a food is medicine, where we are not just teaching people, but we are actually giving them the produce. So we have like a produce partner that we use. And so we have a produce prescription. So the dietitian meets with them. And then they write almost like a medication prescription, but this time for fruits and vegetables. And so they write the prescription and then people go and pick up their produce. And people love this. One of the participants was saying that, I didn't realize that whenever I go to the grocery store, I tend to only pick a type of vegetable, the ones I'm familiar with. But now I like to go for the colors. Vegetables are different colors. And just looking at the baskets that I get, I love it. And so I go to the store. And that's what we're trying to do, modeling behavior, changing people's behavior by telling them this is what you can do differently so that when people go themselves to the store, they gravitate towards more vegetables. They know how to cook it now. They know how to make sure that they can cook it in a way that would improve their blood pressure, not make it worse. So those are some, these are examples of ways. There are other things that our team is doing. We're trying to do like a mobile app as well. So we're trying to do that on a mobile app so that it will be easy for people to access. And so people can just go on, they have like a little, like an agent that they can talk to, ask about this. Is locust beans good for me? Is it not good for me? But, doing it in a way that will be convenient for people. So those are things that are still coming, trying to make it more digital. But these are examples of some things that people can do. I also really highly believe in those are our WhatsApp group that we have. Some of us have like 1 million WhatsApp group. We can actually encourage, we can turn them into accountability groups. If we have groups of friends, we can turn them into walking groups. On a Saturday morning, everybody, 10 a.m., let's do a walk, right? We have prayer groups. We can turn them into walking prayer groups, especially now in the winter that everybody wants to sit at home. No, let's get the winter jacket on. We can pray while walking. There's nothing wrong with praying while walking. Those are some things that we can bring into our daily lives that would not inconvenience us, but that will fit nicely into what we already do.
Yeah, and it's so important because many people just stay home anyway, just laying down on bed on their phone all the time or WhatsApp group back and forth. And we could implement so many other things into our daily life. And I want to ask you, there's a possibility to reverse diabetes.
Yes, especially for pre-diabetes. Yeah, but please finish. Sorry.
So how does that work? Because people may not know that I could reverse diabetes, I could reverse high blood pressure by every day of the choices that I'm making.
Yes. So for diabetes, especially pre-diabetes, so pre-diabetes is when A1C is between 5.7 and 6.5. So it's not quite diabetes yet, but it's trending towards the direction. Pre-diabetes can be, yes, it can be reversed. It can be reversed by strict lifestyle changes. So diet, exercise, more sleep, ensuring that, we're keeping our lipids and other things under control. Those can help. But specifically for pre-diabetes, diet and exercise can really help to reverse it a little bit. Now, for diabetes itself, that's when it may get interesting. But and I'm sure you've heard of this, people may have heard of this, the GLP-1s, the semaglutide, those medications, yes, people publicize them for weight gain, but they're actually quite effective for diabetes as well. There are specific agents with specific dosages that are very, very effective, and they can help as well. But I'm only saying this for people who if you have a primary care provider, can bring it up so that they know your health history, they know if it will be good or not. So for those who have diabetes, you can have that conversation with your
So you're talking, sorry, medication like Ozempic and all those stuff.
GLP, yeah. We know that people talk about them as weight loss, but that's not really. For some of them, they were actually made to control diabetes in particular.
And that's what they actually advertise it for. That was the main purpose for people who have diabetes. That's who supposed to be taking that medication. Not some of these people now who are now have it for weight loss. So I guess a capitalistic system, drug company, they say, okay, it's more money in their pocket anyway.
Yeah.
But we don't know the repercussion of it later on.
That you're absolutely right, because we have not studied them enough to know what the long-term impact is. And that's why I said, please don't just pick it up and start using this. People should talk to their healthcare providers first to see whether it applies in their situation. But for people who have pre-diabetes, it is very possible to reverse it. Strict diet is one of those to reverse it. Doing more physical activity, a lot more than we already do, is one to reverse it. For those who already have diabetes and they are on medication, something I'm passionate about is medication adherence. It is important. Those medications are they can be life-saving. Please, people should not just go off their medications without the advice of their physician. Sometimes, like you said, their diabetes, their pre-diabetes may be completely reversed and they may not need that medication. That does happen, but people should talk to their physician first to make sure that they've gotten to that point where they can now either reduce the dose or completely go off the medication. For hypertension, it is also possible. I've seen cases where people actually, their dosage was, the dose they were on was significantly reduced because their blood pressure is now a lot better. And what are the ways to do that? There's something called dietary approaches to stop hypertension. Actually, one of the studies that we just finished is called Thrive for this medicine study. That's what we did. We customized the DASH diet to people, and we had a lot of African immigrants in that study. So we customize the DASH diet to our community so people understand. So the DASH diet is one. And the DASH diet, the key thing is low sodium. So for some of us who we cannot eat without seasoning cube
Yeah,
and
Maggie.
salt, right? People will say, the spirit that doesn't eat salt, it won't it will survive. No, no, that's not necessarily the case, because if you eat a high salt content, it does have an impact on the blood pressure. The blood pressure will tend to increase. And the kidneys as well does not like that. So we have a lot of people in our community with kidney condition who don't even know it, because it's actually there are a lot of people with reduced kidney function who don't even know, because they are not going to get annual checks. So if people can reduce their salt content, just try it. Instead of using a lot of seasoning cubes, use herbs. Just try and see how the palate adjusts to it, right? People can even use our traditional, the non-salted one, like the locust beans and those ones that are non-salted. If they want that, that taste from back home, they can use that instead of adding too much salt and too much seasoning cubes. So those are ways that people can reduce. And of course, always physical activity. People can actually reduce their blood pressure that way. I will say two other things and then I will stop. The other one is actually checking the blood pressure. So in all of our work, we do something called home blood pressure monitoring, where we actually give people the device. And we say, check yourself at home every day if you can. Wake up, check your blood pressure. Because again, if you don't know the numbers, it's hard to know what's really going on. So we encourage people, we can buy it. If people have, $50, $60, they can go on Amazon. If you want to know if it's validated, and I can share that link with you to put in the description, validatebp.org. You can check if you're trying to buy a blood pressure machine and you want to make sure it's a good one, just put the serial number in validatebp.org and it will tell you whether it's good to use or it's validated or not. So people should please, check, have a blood pressure machine at home, just check. It's non-invasive. It's quite easy to check. And we found out that the ones that people even do by themselves at home are a lot more accurate than that one check that we do at the doctor's office, where you've not even rested, you just ran into the office because you were late for the appointment and you're sweaty and you just sit down and they just slap the cup on. No, that's not there. You're supposed to rest before you take blood pressure, no coffee, make sure that you're nice and well rested before you take it. And that's why the ones from home sometimes can be a lot better. And then the other thing I was going to say, there's something called lipoprotein A. It's a new genetic marker. We call it LP LP and then small letter A. If people who are physicians, primary care providers, when they are going in, they can ask their physician if they can please test for that genetic marker. And I'll tell you why. We found that among people of African descent, the genetic marker is actually higher. And what it actually shows is for people who are more likely to have high lipids, so dyslipidemia. And we know, and I think some of us know, right? When we go to the doctor, they often tell us that our lipids are high. And then they say, do you use palm oil? Do you use red oil? Don't use red oil. So we in our community know that we already have some lipid issues going on. And that genetic marker can tell us if, we have a genetic predisposition to it, because that would then help us to focus, it will help us to adjust our diet, adjust what we do. So that if we already have a genetic predisposition to it, then it's, there'll be that urgency to make sure that we do something about it. So that's another thing I will encourage people to please check.
The lipid is connected to cholesterol.
Absolutely. Cholesterol is a form of lipid. Yeah. So the name of the test is LP lipoprotein A. It's actually genetic. So it tells us whether we have a predisposition to it.
Oh, wow. Thank you so much. So finally, what message you want to give to African immigrants to take away about protecting their health and the overall well-being of navigating life in the US or in the diaspora?
Oh, lots of messages. But one message I would say, I would start with one, which is that I think it is important that we remember our culture of, collectivity and community. A close friend once said, community is medicine. I think it's important for us to continue to help each other. We don't need to compete. Like we said earlier, the sky is big enough, but helping each other. And I say this just being in academia and knowing that there can be a lot of obstacles, and helping each other does help us a lot. It doesn't bring us down. It adds to us. It actually nourishes and enriches us. It doesn't take away from us. So that's one. In the context of our health, we've spent a lot of time talking about specific things we can do. I think it is important for those who have, insurance and have access please go and see your primary care provider, and you can change it. If you don't like the person or if they are being discriminatory, like we talked about, you can change. Please, this is permission. If you don't like your PCP, don't feel like you are stuck with them. Go and find another person, because it is important for your health to know what's going on. Get that annual checkup. Make sure you know what your numbers are. You know what tell them. If they are not measuring it, tell them, measure my blood pressure well. I want to know what my lipids are. I want to know what my cholesterol is. I want to know what my A1C is. All those things. Tell them to check it. Tell them to check kidney function. Very important as well in our community. And then second to that, we've talked a lot about the health promotion, right? We've talked a lot about diet and exercise. Maybe the charge I will give people today, just make sure you do 15 minutes minimum, please. Minimum, go out. You don't have to lift weights. If you can walk, just go out of the house. It's also important, like we said, during fall and winter, we need some vitamin D too. So just go out, a little bit of sun, a little bit of fresh air. It does help. It does help the heart. It helps the body. So those are important things I would say. And then I would talk about, because I would be remiss if I don't talk about this. We talked about that as well. Medication. For people who are on medication, please take your medication. Medication adherence is important. If you want to stop it, a conversation with your physician first. Don't just stop taking it, because there's a reason you're on it. Or if you feel like it's too much or the dose, you can have this conversation. That's why we have healthcare providers to support us. And then lastly, I would say in terms of research, our team, we have a lot of research coming out, and I know a lot of my colleagues who do. I'm going to urge us, please, let's participate in research. Please. That's how we know what's really going on. All the things that we just shared with you, in this discussion, we only know them because some people participated and were able to understand. But that's even a little bit. It's a tip of the iceberg. We haven't even dug deep enough. And the reason is, like I said, our people don't like to participate in research. We say, no, leave me alone. No, I'm fine. Please. If we don't participate, let's think of our children. We won't be able to understand to make their own health better, and our grandchildren. So it would be nice, it would be good if we participate, so we can improve all of our overall health.
And you are so right about participation, because many of us who came here at a later age, back home, there's no health history of our parents. So we don't know what is in their system. So when you come to this country, they say, oh, do you have historical disease or health issue, this and that? You don't know. Did they, any one of your parents have high blood pressure? Did any one of them? We didn't know, because, there's no health history that is attached, in where we came from. So it's for us that we're here to actually create that for the benefit of our children who were born here, so that they will be able to connect that history to themselves on how they too could live longer. Okay, because it has an impact. Like you said, tó bá ń bọ́ gbé, wọ́n gbé. That means if they say carry, everybody should carry, so that it won't be dumped onto your backyard. So we have to participate. Is nothing about people getting into your personal life or anything like that. It will just take a few minutes for you to fill out this survey and respond to things, because it will benefit us as a community in general. So thank you so much, Dr. Ogungbe. Thank you. I can't thank you enough for sharing your knowledge, for the incredible work you are doing to bring attention to African immigrant health. This is conversation really remind us that prevention is not just medical. It is cultural, it is community, it is personal. Too often, we wait until something becomes so serious before we seek help. But taking small steps early, like getting regular checkup, like Dr. Ogungbe said, staying active, paying attention to stress, diet, can make all the differences in preventing heart disease and other chronic conditions. For everyone listening to this, let us start changing our mindset. Let us talk about more health openly. Let us talk in our home, in our community gathering, our churches, when we're sitting with each other, our churches, let's talk about that. In the mosques, let's talk about that. Instead of bothering about unnecessary conversation that doesn't bring any impact into our own personal life. So let's encourage one another to take preventive care seriously, because our health is our foundation. So Dr. Ogungbe, thank you again for helping us to understand how migration, culture, and lifestyle all shape our well-being, and for reminding us that it's never too late or too early to take care of your heart. To our listener, thank you for tuning in. If you find this conversation helpful, please share it with others, somebody in the community. You never know what life it might impact. Until next time, stay informed, take care of your heart.
Thank you for tuning in to this episode of Ponzo Ponzo Live podcast. We hope to have you back with us in the next episode as we continue to explore the nuances of the African immigrant experience. If you'd like to connect with us, you can email us at talk@ponzoponzo.org. That is TALK at PANSA.org. And follow us on Instagram at pansa.pansaforum. Until next time, remember to spread kindness and love. Thank you and take care of yourself.